Welcome everybody to the launch of the Prince of Wales Precision Care Clinic. My name is Natalie Taylor. I am the Director of the Implementation to Impact team and the Director of Research for the School of Population Health. I'm also the Principal Investigator for this MRFF Rapid Applied Research Translation funded Precision Care Clinics initiative. Just before we start, I'd like to acknowledge the Bidjigal people who are the traditional custodians of this land. I would also like to pay my respects to the elders, both past and present, and I would like to extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. To summarise what's going to happen over the next couple of hours for our in-person and online attendees, we will have 4 speakers with expertise in precision oncology. After these presentations, we'll have a panel session chaired by our consumer research partner, Catherine. And in terms of housekeeping, please kindly switch mobile devices to silent mode during the event. Masks are available at registration. The session will be live streamed and recorded, and bathrooms are available on the left. Just walk past the kitchen, through the doors, and they're on the left-hand side. So I wanted to first talk to you about the precision oncology paradigm shift. So this has the real potential to affect all domains of cancer care, from risk stratified early detection and prevention to end-of-life care. These scientific advances are changing the way that we need to think about managing cancer in healthcare. We know cancer clinics will look very different in 2040. How will this happen, and how will the health system keep pace? With any paradigm shift in science, there comes a chance to do things differently. Whilst precision oncology requires conventional phase 1 to 3 trials with the usual patient-centred endpoints, the integration and evaluation of precision medicine into the health system should be undertaken with its own research designs. We have a short window to help prepare the system for the significant changes that are already underway, currently driven through private or research-led mechanisms which are progressively exacerbating inequities in healthcare access. Evidence-based implementation frameworks are required, which build upon observational studies and trials in real-world practice settings and equip clinicians to capitalise on precision medicine advances as part of the standard of care. Undertaking simultaneous implementation and economics research will enable health system managers and policymakers to justify the allocation of resources to optimise affordability, sustainability and access to precision healthcare. Crucially, this kind of multidisciplinary work can enable the translation of genomics-informed treatment into the clinic whilst reducing the fragmentation of care for patients and the implementation burden on clinicians. And so it is with this background that I'd like to introduce the first clinic emerging from our MRFF-funded Precision Care Clinics initiative at the Prince of Wales Hospital. And to kick us off, we are incredibly lucky to have Professor Boon Chua. Professor Chua is a consultant radiation oncologist and Professor of Medicine at UNSW. Professor Chua holds an exclusive clinical and academic subspecialisation in breast cancer and leads a programme of competitive grant-funded academic oncology research in collaboration with cooperative clinical trials groups worldwide. Welcome, Professor Chua.
Thank you, Natalie, and good evening, friends and colleagues. It's my pleasure to be here today. So in more recent years, we have witnessed the convergence of extraordinary progress in cancer molecular biology, the genomics and bioinformatics, and therefore the time and the climate, I think, are right for us to realize the promise and the ambition of personalized cancer care. However, as with many sectors across health, there remain challenges in translating and embedding the promising results of cancer clinical trials into routine practice and patient care. And therefore, this precision care clinic, it is a scientifically innovative and clinically pertinent partnership between health and science to transform the way that we control cancers. And we will test the effectiveness of precision care in routine practice and the value of precision care to the healthcare systems. And these two are not mutually exclusive. And we thank the Medical Research Future Fund for their strong support of this important initiative. And without their support, this would not be possible. So very briefly, I quote from my address for the official opening of the Nalun Comprehensive Cancer Center of the Prince of Wales Hospital in 2017, that the Nalun Comprehensive Cancer Center, which is purpose-built for integrated cancer care, research and education. And this building signifies our commitment to innovation and discovery and compassionate patient care. And therefore today, we're delighted to launch the Precision Care Clinic to provide an evidence-driven advisory service in precision care to support peer discussion and enable shared decision-making with our patients for timely individualized cancer care. So to our outstanding investigator team, congratulations, and I wish you every success on this important initiative. Thank you.
Thank you very much, Boone. That was fabulous. Next up to the floor, we have Professor David Thomas. Professor Thomas is the Director for the Centre of Molecular Oncology at UNSW and the CEO of Omico, a national precision oncology platform applying genomics to develop biomarker-dependent clinical trials infrastructure. David's transformative research has driven a range of direct changes in health policy and practice. Please welcome David to the floor.
Thanks, Natalie, and it's a great pleasure to be here. It marks I think, probably something we should all recognise as what a critical step this clinic represents in the general story that is precision oncology. Things are developing incredibly fast. Science is impacting on the way that we think about cancer, and the ultimate test of science since the Enlightenment is the ability to use that insight to intervene in a way that predicts success. And what's happened over the past 25 years, since the late 1990s, has been the progressive implementation of a set of tools that allow a genetic disease to be tackled in a scientific way. So that in the 1990s, a phase 1 trial patient had a 5% objective chance of response when offered a cytotoxic. And it was where many sarcoma patients went because there weren't trials for sarcoma patients, as for many rare cancer types. Today, that's still true. If you offer a cytotoxic or a targeted therapy that's not directed towards the patient who's got that target, the objective response rate remains around 5%. But if you match the molecular profile of the patient to the drug, then that jumps to 31%. As a consequence of that, genomics, bioinformatics, computation, robotics, artificial intelligence with drug development, the landscape today has radically transformed such that, in my view, every cancer patient ought to have access to this technology, and through this technology to the interventions which actually make a difference in patients' lives. There is no statute of limitations for genomics in cancer care. It isn't a test. It's not a gene test or a immunohistochemical test that can pass through MSAC. It is literally like applying the light microscope in the middle of the 19th century. It's a way of thinking about the disease that has consequences. All very well in science. I've spent the past 12, 14 years of my life progressively working up molecular profiling, primarily based on genomics, through stages, 1,000 patients, 3,000 patients, currently in the middle of a program that's 23,000 patients. We can see the doubling of survival in patients who get benefit. We can see that 40% of patients will potentially benefit if we can get the right drug to them. There are still an enormous number of challenges, but it is well past due for us to think about the ecosystem, the health system itself, as a legitimate object of research, evidence-based evaluation of how we integrate this into clinical care, how we bring together disciplines which are normally quite separate together to work in a patient-centered way, how we bring clinical trials from being an accessory to being something that's mainstreamed, and all the consequences of that. And indeed, all the way up, in my view, to the cabinet table, and governments will have to integrate departments which have traditionally not been allies to try and think about how we're going to afford all this in a sustainable way in the longer term, and what it means for our country, the region, and in fact, beyond. So I think it's extremely exciting, and congratulations to Natalie, because it's ripe for the taking. This is the first clinic that I'm aware of that is specifically focused on this model. It is not a phase 1 clinic. It is but it has that agnostic approach that phase 1 has, and it's using that template to ask, how do we provide the power of this technology in an evidence-based way, and how can we measure how it influences the system? So I'm going to be very excited to see whether you get an MBS item out of this, so that we can answer some of the questions about long-term sustainability in the healthcare system. Well done.
Thank you, David. Oh, I've gone to the end. So sorry. That was David's slide. It gives me a real great pleasure to introduce Associate Professor Kathy Tucker to the stage. She's a leading expert in cancer genetics, pioneering the first Australian familial cancer service. Associate Professor Tucker holds a conjoint position at the UNSW Prince of Wales Hospital Clinical School, and is committed to advancing genetic services and policy development at local, statewide and national levels. Welcome, Kathy.
Thank you. I feel very privileged to be in this position in my career. I think that being able to use tumour testing in a patient who's very unwell to then be able to move that to prevention in their relatives is just, I couldn't have imagined it when I started. So just have to make sure that it is working. I'm going the wrong way. Yeah. Maybe if I move the cursor to here. Yeah. Don't panic, Kathy. Just do what David almost did the other day. There you go. So just to do a quick, for those people who don't know genetics, germline genetics just means what you had at the beginning, that fertilized egg. So in some genes, somatic changes give you an idea that there's actually likely to be a germline, and the classic is BRCA1 and 2. And my interest in the germline genetics and how we can use it and how we can find the germline changes in patients with poor outcome cancers to improve things for them and their families is what's driven me to this collaboration. There's why look in the germline, in the tumour, to see if there's any germline? Well, two things. The first is that if you have some particular genes that if the change is present in the tumour, it's likely to be in the germline, then and those genes are known to have a classic clinical utility for the person and their families, then that's really a win-win. So if you have a BRCA1 tumour result in somebody who has ovarian cancer, there's a 60% chance of identifying it. And we have now very good evidence that we can change people's outcome in by preventive and management strategies. So the other situation where you can use this, if you have a mismatch repair gene in the tumour, then you either in colorectal or endometrial cancer, then it's likely that there'll be a germline mutation, and that germline mutation has implications for the patient in terms of their care. It has also implications for their relatives. If you know that there's a germline mutation, then you can actually save lives for the relatives. So you can't test everything. So tumours have lots of changes and a lot of those are not germline. And sometimes we only find, so if you have a TP53 mutation, for example, it's very likely that that's just part of the normal tumorigenesis pathway. And I have to get it to work again. So in this situation, if the patient has their tumour testing, as a byproduct of that, we're actually getting changes for their cancer management, changes for their family, and it allows us to make life-saving changes. And in the beginning, when we started this, it was really hyperbole to talk about changes, but actually now we've got good evidence. So the next thing is, so why use Germline Precision Care Clinic? So anecdotally, these people who've been tested through David's 23,000 people get one of these genes that potentially has a germline. So they're unwell. It's hard to get into the clinic. The family cancer clinics have waiting times of up to a year, which is actually not very useful. So what we do then is, if we're testing we're validating whether it's germline or not, we use very good genetic counsellor who you're going to meet in a little while. And then we establish whether those people need to be referred to the family cancer clinic for their relatives or not. Now, the second thing is that there's value in leverage. So two Davids have their team, and they, with my team, with Melita and Bridget, the total's more than the sum of the parts. So, for example, if you've got a known BRCA2 mutation, and Maury, this is probably, no, it wasn't your patient, it was somebody else's patient, but the discussion was about, she had a BRCA2 mutation, therefore maybe she needs a PARP inhibitor. But actually, if we looked at the tumour, there was no evidence of any failure of the BRCA2 working. So then we know that it's going to be a waste of time, a waste of money, and she doesn't have a lot of time. So she needs the right treatment. And I need to keep going. And I will just go to which genes. So we always offer testing in these genes because of the high likelihood and the high clinical utility of finding something. The second lot of genes we only offer based on various criteria. And patient consent is something that people always worry about. The possibility of a germline mutation is important to flag during the consent process, but to be fair, the patient's very unwell. There's lots of things that are being discussed. It's actually not really very easy to discuss the implications of that. So the value of having the precision care clinic is that they get to talk about a genetic counsellor with a genetic counsellor if they've got a high prior probability of having a germline mutation. And my last slide, if it works, is the public health component of it. So this patient group's very worried about their relative risks. There's a lot of evidence about that. And we, in a different study, looked at the delivery of unexpected genetic test results. We looked at a whole lot of people who had breast cancer. We went back and tested about 5,000 of them with new tests. And then we went back to the relatives or their next of kin, to the patients or their next of kin. And what the evidence came up was that there was initial distress, but it was short-lived, and the process of readjustment and meaning making and adaptation was actually facilitated by their clinical and personal utility of the information. So the results were overwhelmingly positive, and that's been published here in this study. I just wanted to say the last thing, so that because of this public health benefit and the interaction between the clinical teams, we really, I really think that cancer genetics is an important component of the Precision Care Clinic. Thank you.
Thank you, Kathy. And next up, we have Professor David Goldstein. Professor Goldstein is a senior medical oncologist with multifaceted clinical interests, centering on the treatment of gastrointestinal malignancies. Professor Goldstein has been involved in clinical research projects ranging from laboratory basic science to novel therapeutics trials to psychosocial aspects of care. Welcome, David.
So it's a pleasure to follow my previous speakers, and really it's always humbling to be with visionaries and to have the job of helping translate their vision into practice. And I think that's what I want to talk to you about now, is the how. And yes, it worked. So this is a project. So we will try to understand the known knowns, the known unknowns, and the unknown unknowns. And once we get that right, it's going to be rolled out to some other clinics around the country who will have their own unknown unknowns. And then we will be able to articulate how to bring into practice the vision. So that's what the next few years involves, under the guidance of our leader, Natalie. But underpinning this is a thought process. So a specialist clinical team, people with diverse backgrounds and specialist interests, particularly bringing people who really understand about genomics, our geneticists, the scientists who understand the process and the pathways, and the clinicians who can put the perspective of this patient with this particular problem at this time in their journey. That's what the clinic's really about, is a fusion of all of those things. So in a sense, it is a novel, it's not a novel model of care, but it's a novel model of tools within the care process. And the other really important part is there are so many reports and so many ideas and nature papers that don't proceed to practice. And it's only the idea of implementation science and changing this huge inertia within a big bureaucratic system that of necessity has to be slow to change to not cause harm, but needs help in order to not only not cause harm, but actually cause change. So that's what the whole process of this project for the next 6 years is about. And the most important thing is it's a rapidly learning system that changes and evolves. It's not static. It's not an idea. We will be not doing it this way in 6 years' time. We'll be doing it entirely differently, but I have no concept of what will be different. So just specifically about this, it's taking curated laboratory genomic data that says these are possible targets, but actually then thinking about this patient at this point in time and what makes sense for them. And the goal is not to take over care. The goal is to help with shared decision-making for the patient and their principal clinicians. And the beauty of it, I mean, this is the first research grant. I've worked with Kathy for nearly 20 years, and it's the first time we've actually are together in a research grant. So it's a great privilege. Genomics, genetics, and therapeutics. And as I said, implementation, strong clinical and research foundation. All of the principal investigators have got a good, solid, strong background to bring to this idea. Ultimately, it's about mainstreaming this service. That's what it's about. It's not about having an empire of precision cancer clinics. They will disappear because everybody will think it's normal. And then we'll have achieved our goal if that's the way it's thought about. So we're going to look at pathways and reasons for internal referral. All of my colleagues understand about personalised medicine. They understand about targeted therapies. They've been doing it. Beatson did the first targeted therapy by taking ovaries away from breast cancer patients in 1900. There's a long history, but there's been an avalanche of new science and understanding. So it's less hit and miss now, and we just have to develop how to do that, how to bring that into mainstream care. We hope we'll replicate a cancer centre's capacity to deliver precision care well beyond cancer centres, but the most important thing is to maintain mobility and trust between referrers and expert panels. I have to say I stole that from one of the speakers from last week, if you remember. So what are the components? Get a referral, have an MDT meeting of the people with these different specialised backgrounds that come together, decide if a clinical consultation should be part of coming to the decision about the summary letter that gets sent back to the caring team. So therapeutic advice and recommendations based on the information that comes principally from CAS, but potentially from other laboratories that offer similar services. Sometimes, maybe more than sometimes, identifying local and international experts to provide input and perspective. A hierarchy of potentially suitable trials that are not only just about the molecular profiling, but the clinical circumstances and the geography. That's where the equity idea comes in. And occasional rather than routine patient consultation is certainly my perspective. And then all these other bits that Kathy's already covered that are part of the global service. So we're going to accept Australia-wide referrals about patients who have tumour molecular results and whose clinician thinks further review and interpretation is needed, including genomically informed treatments. We've got a multidisciplinary team with a variety of backgrounds and a skill set, and then provide report and amplify the evidence base that the clinician and the patient have been given. So it's not a second opinion. It's not providing the opportunity to transfer care. That's not what it's for. It's to guide uncertain and help resolve uncertainty, clarify options, clarify what the variants mean, and assist in the subsequent management plan. We have both a medical oncology component, a genetics component. There's a lot of workup involved. We generally would like to know what's the molecular medicine question that has caused the patient to be referred, and because that focuses our way of thinking about that patient. So referral, an initial engagement or clarification for the patient and clinician of willingness to participate in the research that inevitably results from seeing patients and understanding variation in biology and individual influences on outcomes. The MDT clinical consults is required, and then a summary letter. And so my minute has gone successfully, so it's my pleasure to introduce the start of our panel. So our chair, Catherine Leaney, is someone I've also worked with for a number of years. She's a very vocal and determined advocate for patients. She's been involved for a long time in the consumer panel at UNSW, both Sphere and before that the TCRN, and she's also been a co-investigator and a contributor to the research activity. So she's eminently well, including this program and eminently qualified to lead us in this discussion.
Thank you, David, for that introduction. And I'm honoured to be involved in this whole project. It's absolutely so exciting, and it's wonderful that we've got to this stage now. While the team sets up, I'd like to introduce the panel members. Two of them you've already met, David Goldstein and David Thomas, but I'd like to introduce the other three. So Dr. Melita Zahir is a cancer genetics specialist at Prince of Wales, and she leads the cancer genetics stream of the Precision Care Clinic. And her expertise lies in the identification of patients who may unknowingly carry an unrecognised germline pathogenic variant. I've learned to say some very big words while I've been involved with all these researchers. Dr. Frank Lynn is Honorary Medical Oncologist at Prince of Wales Hospital and leads the medical oncology stream of the Precision Care Clinic. And his research focuses on genomic decision-making and the development of biomarker-linked oncology trials. And he's also a bioinformatician. And that's another big word. Ms. Bridget Douglas is Associate Genetic Counsellor at the Prince of Wales Hospital Hereditary Cancer Clinic and works with Kathy. And her role is, and this is a role dear to my heart, to help patients and families navigate the multifaceted aspects of cancer genetics care by making complex information accessible and ensuring informed decision-making. So I'll just go through some housekeeping. We'll take questions from the floor. There are 2 roving mics, and if you put your hand up, I will point to you. A mic will come to you. Please don't speak until you've got the microphone. Can you say your name, where you're from, and if there's a particular member of the panel that you'd like to address your question to? And be brief to the point, because we don't have a lot of time for this. There'll also be questions coming in from our live streaming, and Natalie will interject with some questions from there as well. That we've only got about 15 minutes, so if we don't get through all the questions, the team will do some FAQs and put them on the website. So as the cancer consumer on this project, it would be remiss of me not to say that while the clinic is absolutely fantastic, don't forget that you'll be dealing with people like me who've been diagnosed with cancer, treated to a point where they almost feel, you know, what is left. They look to people like the panel for the cure, for making me well, for helping me live longer. So that's really important. The process is fantastic, but don't forget that really all you're doing is making sure that people like me are able to live longer and better. So without further ado, I'll ask the first question and give the audience some time to think of a question to ask. So David Goldstein, I'll ask you the first question. So how can the clinic help to ensure that the benefits of precision medicine are shared equitably?
So I think the key is that telehealth and COVID taught us that you don't have to be in the same city as the person might have the knowledge that you need to acquire. And that's exactly the underlying principle of the clinic, that its expertise is really going to be widely available for the appropriate circumstance that's required. I think the other thing to say about the clinic, under David's leadership with CASP, the whole project is moving towards the earlier stages of treatment, and it's no longer about, well, we've tried everything else, is there now a molecular solution? The molecular solution might ultimately be the first rather than the last solution.
Great, wonderful. Any questions from the floor? Yes, we have one here. Wait for the microphone.
I'm Maury Agmesha, one of the medical oncologists from Prince of Wales Hospital, and I'm so pleased to hear this clinic is hopefully start to be functional. I had a couple of questions. One was, would you develop any criteria for what sort of patients needs to be referred in case of, like, you know, an inpatient or someone with ECOG 3 or 4? Does it matter? I think it would be good to know, is there a criteria for referrals for, I guess, you know, our sites, but also other sites? And the second thing is how we're going to measure the outcome in case of impact on the sort of long term. Is there any procedure to monitor it as well?
been told to put this on. So yes, I mean, certainly, I think a lot of the referrals are going to come. Actually, a lot of the genesis of this came from the experience of giving reports back to clinicians and then fielding a lot of calls and emails, seeking clarification about what is often ambiguous. We had a molecular tumour board over the weekend where, for an interesting case, admittedly, but 5 experts ended up spending 15, 20 minutes trying to come to what was in the best interest of the patient. And in fact, we actually ended up emailing somebody afterwards to get that result. It's that circumstance that we want to provide all of those services in the one place, and it can be graded from an email. Can you clarify all the way through to this is really complicated. Would be happy to see the patient in person, because as a molecular oncology board, you don't have the clinical context that a clinician who looks after the patient does. And it's just designed to give you, the all many some few concept where some people really need to be physically seen. Many people can be handled by supporting the clinician, and the rest, I guess, we hope can benefit. So the people that we're referring in are people with advanced cancer who are from first-line metastatic onwards, where you think that there may be some benefit from getting molecular profiling and potentially identifying possible treatments and trials. And the other circumstance, I think, sorry, I should actually, maybe I'll hand over to Melita, because otherwise I'll skip. But about the germline, Melita, tell us about what you think about the germline.
I was listening to you, David. I wasn't glaring. So I guess from the germline side, it's really we are collaborating with the CASP program and really capturing those patients who are having tumor testing through CASP. And the CASP program now is offering recommendations to clinicians about germline testing, and it's just about providing another avenue for people to be able to access the tumor profiling in a centralized system, so they can access germline testing at their local center. But as Kathy already mentioned, sometimes the wait times can be quite long, and sometimes, especially I guess if you circle back to the regions and equitable access, Sydney is quite fortunate, but not all the states have and also even, in the regions have the same access as we do. So it's about sort of providing that equitable, broad access for tumor germline profiling, a germline testing that comes from tumor profiling.
Sometimes what the clinic has as tools are things like.
Sorry, David, can you use the microphone so that people online can hear?
Oh, I see. Sorry, I beg your pardon.
It's okay.
But sometimes the tools these guys have just are not available to everybody. Like the SMOC program, you might want to talk about whole body MRI. There are some people where we find these really odd patterns, and we want to do something. We don't want to. It goes beyond the current standards of care, even in the germline genetics and risk management space. And I think you've got you're tooled up to be able to potentially offer those.
Yeah, so at the, I guess at the Prince of Wales campus, we do have some screening programs available, which Kathy leads, and we also have another clinician who leads another surveillance program. And often the patients who will come to us might not be the right patients because they obviously have advanced cancer, but it's for the benefit of the relatives. There's also pancreatic cancer screening study. And so often thinking about the criteria for that that an individual might need to meet to be able to access those screening. We also then we will assess something in the germline if we think that this will mean that there's someone else, a relative, will be able to access screening, which sometimes that nuance isn't, it can't be expected that that nuance will be well appreciated across the board in a different field in oncology, and that's sort of something that we can bring.
David.
Just quickly to add, not take more than a short space of time. So the KPIs about benefit are going to be both qualitative, so both the patient and the referring clinician are satisfied that they got what they needed to proceed down a pathway, and more importantly, changes in treatment plan will be a key KPI. Did you actually, as a result of the consultation, end up following a different treatment plan or enroll patient in a trial that you would not otherwise have done.
Oh, okay. Yep, sure. So
Thank you. Really cutting edge, amazing
can
technology.
you
and
say your
science.
name and where you're
Freddie
from?
Cetus, I'm an epidemiologist, so you're going to know the question I'm going to ask. In 6 years' time, what are you going to be comparing your cases to? The ones that have gone through the system and the ones that have ... I don't know.
That's complex because we're not going to collect retrospective data on outcomes of matched pairs of patients in a place where there isn't precision medicine. And the success of CASP will mean that almost every centre will have molecular reports and probably act on them. So I think we're just going to look more at our outcomes and say this is what we've achieved. I don't think we'll be able to say this is infinitely better than the previous system. That would be a bit beyond, at least I think Natalie might think she's going to do that. I better not say that she isn't, but that'd be my thought.
Richard, I've got a question for you and we'll come back to you. So I believe you've already seen about 20 patients, 20 clients for genetic counselling. So what's been your experience of regional patients accessing the service?
So yes, I have seen, I think 22 to date. They've been from every state of Australia bar WA. I've seen them on telehealth. I've talked to them on the phone. I talked to one man who was a truck driver and I was on his journey through regional Victoria. Hopefully he was hands-free. Yeah, I see some New South Wales patients face to face, but the majority of them have been from out of state, actually.
So there's no limit to how you can provide the service to anyone?
I work with what the patient has available. Some patients don't have computers or so that was the phone. Telehealth issues happen to everyone. So then we revert to phone. I can do my job via phone. Yeah, so yeah, it's good.
Great, wonderful. Now you had another question.
Sorry, I
There's
guess
one
just while
here.
we're doing that, just in terms of the outcome measures for the germline side, we know that there are a lot of missed heritability. There are a lot of people who never get referred to clinics. They're just not recognized. And we already know that because by the time they come to us, if they met criteria, they should have been referred. So we can capture all these people who haven't accessed the normal pathway, the routine pathway, and so they are coming to see us. So we are capturing this data as we speak.
Good.
Just to give you a sense, 5 to 8% of patients in our program. Just to give you a sense, 5 to 8% of the patients that come through the program have a germline event that Melita gets concerned about. It happens 2 to 3 times a week that we can. So it's a significant clinical issue.
I was just going to add to that KPI measure. Maybe what I'm just suggesting, maybe one way would be to see the patients who had CASP and not referred, compared with the CASP and referred.
It's true. That's true.
Natalie's saying they're doing that. So we've got a question in the middle here.
Hello, Tony Roscioli. I'm one of the genomic leads at New South Wales Health Pathology, Randwick Genomics. Great steps forward, amazing stuff. My question is really about the people who are coming to you for help, who have something other than cancer as well, because people will have more than one thing. What's your approach to germline testing in those people?
Oh, well, you're touching on something that I've been agitating about in the clinic, and we've sort of changed. So when we envisioned it, it was really for cancer. And then we have recognized that there are people who have a genetic syndrome, which is where we can potentially exploit oncogenic cellular pathways by using treatments. So, for example, currently I am working on a patient from, not from this state, who has Noonan syndrome related to a KRAS mutation with progressive loss of mobility due to neural tissue thickening. So it's not malignant, but as a team, we discussed her case and we felt that a KRAS inhibitor may be something that may provide her with some benefit. There's only one report of such a case in the whole world, and there's no report of anyone having had treatment. So again, I guess the benefit of this clinic is it's allowing us to explore those opportunities, which I guess those are patients that there's a real gap in care for them at the moment. So that's my hope and vision to get there.
It's a very good point, Tony. So we've got a program where we're doing whole genome sequencing on people with early onset cancers called RISC. And we're turning up in the ACMG list a whole lot of genes, variants that are affecting genes like pharmacogenetics, DPYD, things that might influence the care. And we're not quite sure how we're going to deal with that. But what you want is to have an environment where you can bring in expertise as required to deal with those cases. And I think that's probably how we will do this. I think we'll probably depend upon calling in experts as required in a patient-centered way. Is that what you were thinking about? Stuff like
One
that?
of the things, yeah.
So the other thing that Melita's answer exemplifies is a question that has been asked that we otherwise might not have covered is, how are you going to incorporate research into care? And you've just heard a perfect example where a case comes and it then generates research projects and potential interventions.
You've just taken my last question, David. Natalie, I'll have to think up another one. Natalie, you've got a question from the online group.
Yep, so I think this is probably a Frank question. What exactly is the learning health system and how does it work in this context?
Yeah, thanks. Great question. So I'm kind of, well, first, I'm lucky to be kind of humble to be involved in this group and being involved with this clinic. So one thing about precision care is it's all about the information that we have. So the more information that we have, and there's also a lot of uncertainty as going forward. So one of the challenges that a lot of this will be very low in numbers. So the way we actually deal with this will be to the traditional trial or cohort studies when it will be a very challenging thing to do. So learning health system is a way that kind of collecting data and try to learn from each case. This actually fits in very deeply in the MDT style, the way that we're actually doing. So we're going to analyze each case in great depth, so we can actually use this to drive both research agendas and try to collect information systematically. Then we use all the different informatics tools and including artificial intelligence tools to actually help us do design new studies and look things. So it's very early days, but we are rapidly, and I think our team, I'm very lucky to have Jeff and one or other postdoc working with me. So we're actually working this. Well, hopefully we'll turn this into this part of innovation strategies.
Great, thank you, Frank. Now we're 4 minutes to go, so we'll have one last question.
My name's Helen Goldsmith. I'm the Research Development Manager with Sydney Children's Hospitals Network. As a researcher, we always look for innovative ideas, and one of the things that I've alluded through your project, which is fantastic, and I'm very excited. I think this is, very innovative work, and with lots of partners that are going to make this happen. You had a referral document that is emailed. Is there been any consideration, maybe understanding that we're looking at researching and pulling data together, to potentially use something like a REDCap service to be able to share links with clinicians, to be able to put referral forms through? That way you can potentially put criteria on it because you're putting in the criteria through it. You can put in emails, you can put in, the information that you're required in a drop down, selecting, and it shoots off to the appropriate email. And then in the back end of that, you're collecting your data, who went through, who didn't went through, and that's the start of your process. New South Wales Health, Ministry of Health, have a REDCap service that you can actually put patient identifiers into, FYI.
Yeah, that's great to know. Yeah, thank you.
We are using a little bit of REDCap, and Natalie's been working really hard to see that, because traditionally the REDCap data, it gets entered right at the end, or sort of once someone has entered into the research sort of platform. And so Natalie and her team are working on how we can bring that forward, sort of similar to what you've raised, but actually you're suggesting even earlier, which is fantastic. So I'm sure Natalie will be thinking about this tomorrow.
Any final comments from members of the panel?
I think the really incredible idea here is that a patient that comes in to see you as a doctor, you have these incredible tools to try and focus on their problem, and then the space to find at least a plausible solution in an ethically and appropriate framework. It's sort of like the old Royal Melbourne had a sort of clinical research unit that was a bit like that in the 1960s and 70s. This is a bit like that, but with the tools of the 21st century. It's an amazingly exciting concept.
And I think for us on the germline side, I guess we're thinking beyond the patient, we're thinking about the families and the opportunities that families are likely to receive from being, there's often quite a lot of lived experience and trauma of having watched someone go through cancer. To be able to prevent that in a relative, that's really worthwhile for us.
Yep. Thank you very much. The panel will be around, so if you've got any more questions, I'm sure they'd be happy, and the speakers as well, happy to take them during drinks. So thank the panel. With me. Yeah. Thank you. Turn my
Thank you to all of our speakers and panel members, in particular to Catherine Leaney for being such a fabulous chair. We hope you found the information presented of interest and value today, and look forward to delving into more conversation with you over drinks and some lovely food. But before we finish, please let me tell you a little bit about our website, which I hope that you will visit to find out how to refer patients and more about the research that's underpinning this initiative. And to finally wrap up, there are a lot of people to thank, many who are listed on this slide, including our partners and organisations who have funded earlier work across all of the team, which has really helped us to get to this point. A few special thank yous to the Precision Care Clinics Initiative team. Your vision, expertise and commitment is outstanding. In particular, I'd like to thank Sky, Aria and Jenny for coordinating this event over the past 3 months, and to Shuang, Jeff, Joey, Lizzie and Carolyn for their support, and Eli, of course, today. Please give them a round of applause. We do have a little gift for Catherine for your wonderful chairing skills, but we'll hand that over to you during the drinks. Thank you all for attending, and now you get your reward to enjoy some nice food, drinks and connect with new or reconnect with old colleagues. Thanks very much.